Thanks again, Marcella, for inviting me to participate in this talk today. Marcella asked me to talk about atherectomy devices, kind of a review of the evidence supporting their use and the indications for their use. I have no disclosures. I think it's important when you're talking about atherectomy devices to get at least a feel for what devices are out there, because they're really quite different devices. The one that you probably have heard a lot about is the Silverhawk, and that's actually gone through a couple generations of product, the Turbo Hawk, and their most recent one is Hawk 1. And it's a little hard to keep track of some of the company changes along the way. It started off as Fox Hollow Technologies, was acquired by EB3, and then Covidian, and most recently Medtronic is now the owner of that technology. And they refer to theirs as directional atherectomy, meaning that it's a device, I'll show you a picture in a moment, where you kind of bend the catheter that exposes the cutting part of the device, and then you need to rotate the device through multiple passes as you shave off the atherectomy or perform the atherectomy. Another device produced by Boston Scientific is called the Jetstream, and it is the corporate history there was it started off with Pathway Medical Technologies, was acquired by Bayer, and now is owned by Boston Scientific. And they call theirs rotational atherectomy with aspiration. It's got basically concentric spinning blades that go down through the central part of the lumen, and at the same time they aspirate things. The way that, backing up a little bit, the directional atherectomy, the Silverhawk devices, get rid of their atherectomy debris is to stuff it into the nose cone of the device, and then you take the device out every couple, after several passes, and clean the device and put it back in. So obviously, most of the cases you need to get rid of the debris that you're removing. The exception to that is the next one produced by Cardiovascular Systems, or CSI, called the Diamondback 360, and they term theirs orbital atherectomy, and basically they take a spinning eccentric kind of diamond-coated burr, and again, I'll have a picture of it later, and they really target calcified plaques, and their concept is they're going to pulverize the calcium into such fine pieces that they're smaller than a red blood cell, and you don't have to worry about aspirating them out. And then I also need to mention another way of doing remote atherectomy is by using an excimer laser. There's one company out there that I'm aware of that makes a device like that, that's Spectranetics, and they make a Turbo Power and a Turbo Elite device. And laser atherectomy got a bad name back in the 90s. They started off with different wavelengths, and they were causing too much heating of the device, or the wall and the plaque, and they got into problems with thermal damage to the tissue. The technologic breakthrough with that, with the excimer lasers, it's a different wavelength. It's in the ultraviolet range, and they can break up the plaque without actually just burning it away. And their niche is really in-stent restenosis. So I'm just going to show you a couple pictures of the device, just kind of so you know in your head what you're dealing with if you're not familiar with them. This is basically the Silverhawk Hawk 1 device from Medtronic, directional atherectomy. As you can see, the device a little bit and exposes the cutting portion of it. Let me see if I can figure out how to point with this. Yeah, it's not going to work. But basically, you're shaving off the plaque and stuffing it into the nose cone. The Jetstream, as I mentioned, is a rotational atherectomy with aspiration. So they come with two different catheter types. One of them just has a single rotating set of blades. The other one has a dual set of blades, one near the nose and one set back a little bit bigger. And then the whole thing, they infuse saline through it via a pump, which is in the lower right-hand corner of that picture, basically infusing saline and sucking that out to remove the plaque as you go. The Diamondback is the orbital atherectomy, and again, there's basically a diamond-encrusted burr on the catheter, and it's intentionally eccentrically located on there so that when you spin it, it kind of goes out, I guess, in an orbital fashion and hits against the edges of the plaque. And again, the concept is the soft part of the plaque, this isn't probably going to be especially effective at, but the calcified plaque is going to be pulverized by that action. And then there's just a picture of the Spectranetics excimer laser. They come in a couple different varieties, often done in combination with another catheter that gives it some directionality. The indications, if you look in the IFUs for all these devices, are all basically for peripheral atherectomy, meaning outside of the central part of the body. For the laser device, they specifically say infrainguinal. For the other three mechanical devices, you got a little bit more leeway, at least in the FDA package inserts. They say upper and lower extremities or just peripheral. None of them are intended for use in the coronaries, the carotids, the renals, or iliac vessels. The Jetstream also has an indication for aspiration of thrombus, since remember they're the rotational and aspiration components of that device. And the Diamondback has an additional indication for arteriovenous fistulas, basically if you have stenoses in the upper extremity arteriovenous fistulas. The Turbo Power and the other, which is basically the excimer laser product, has an additional indication for in-stent restenosis of bare nitinol stents, and that's kind of a unique application, at least in the FDA indications among the atherectomy devices. Complications, things, what you'd expect, distal embolization. And, if you put a filter down distal to any intervention, you're probably going to find the stuff. And the PROTECT trial showed almost 91% incidence of some detectable embolic material in the filter when you're using a Silverhawk, compared with about 28% when you're just doing PTA. And in one of the larger Silverhawk trials, almost a 4% incidence of clinically apparent distal embolization. You'd say, well, let's use filters on all of these, but you need to be careful with that because these are complex devices, and technically you really should be using the wire that the company recommends that you use. And they usually have proprietary wires that are specifically designed specifically to be used with their devices. And you don't want them, having mechanical failure. Most of the time, distal emboli can be managed with suction thrombectomy or PTA. And again, the orbital atherectomy particles are theoretically smaller than red blood cells, so you shouldn't have to worry about chasing those down. Vessel perforation in one of the big Silverhawk trials occurred in about 5% of patients, and basically occlusion of the vessel in that same study occurred about 2% of the time. The clinical evidence, the bottom line is it's not especially robust yet, but it's getting better. A lot of the earlier studies, as with most newer technologies, are single center, non-randomized studies, mostly designed to show that the devices are safe and reasonably effective to get their FDA approval. There was a Cochrane review back in 2014. That is a presumably nonpartisan review organization that looks at healthcare and medical technologies, and they do theoretically unbiased reviews. And back in 2014, with their available data, they said the data was sparse and does not support a significant advantage of atherectomy over conventional balloon angioplasty. And most of the studies, if you look through the literature, don't really talk or break it down specifically above and below knee applications. I'm just going to go through some of the trials and studies for the different devices. We'll start off with the Silverhawk device, the directional atherectomy. This is from 2007, a relatively early study. They looked at 66 limbs, and they were fairly sick. These were task C and D limbs, or 73% of them were, and they had a 1-year primary patency of about 62%. Another study using the same device in 2008 had more patients, about 275, and most of them, or 63% of them, were chronic limb ischemia patients, and they had about a 50% 18-month primary patency. This is one of the bigger studies published using the directional or Silverhawk device, almost 800 patients. I wish they'd done it a little bit different. They basically looked at diabetic and non-diabetic patients, and that's what they were comparing to see if there was a difference in the effectiveness of this device between diabetic and non-diabetic patients. It probably would have been even more useful for this talk, at least, to compare it directly to stent placement or other alternative technologies. But they had about a 78% primary patency in their claudication patients, and their chronic limb ischemia patients had a fairly impressive 95% freedom from unplanned major amputation. These pictures, by the way, are from the Red Rock Canyon outside Las Vegas. If you ever go out there and you're tired of the casino lights, go out and do this hike. I highly recommend it. The Jetstream, again, is Boston Scientific's product. This is a study with their device in 2009. Single center, 172 patients. They had a primary patency in the 74% range. And another one, they're doing a registry of these patients, and they're shooting to get about 500 patients. They published some preliminary data on about 155. Didn't really talk about primary patency rates, but basically showed good procedural success and low complication rates. Going on to the orbital atherectomy, the devices from CSI, the Diamondback device. This was a fairly early study, relatively 2012. They looked at 50 patients. Didn't really see much clinically significant or statistically significant improvement in procedure success, bailout stent use, or freedom from target lesion revascularization between that and just PTA. This study and the study I'll show you next basically looked at atherectomy followed with balloon angioplasty versus balloon angioplasty alone. And that was probably one of the studies that the Cochrane Review looked at. Another study, basically with the same device, a couple of years later, 2014, had more favorable results. They, again, relatively small. It was multi-center, but only 50 patients. And again, they looked at atherectomy plus PTA versus PTA alone. And if you had a greater than 30% residual stenosis, they threw in a stent. And they found that there was a big advantage with the atherectomy devices for reducing the need for stent. They only had to put stents in 5% of the patients that they did the atherectomy first versus 78% for just the PTA. And their freedom from target lesion revascularization was a slight advantage, probably not statistically significant between the two groups. The excimer laser data, didn't find a lot of data on them. I haven't personally used this device, but here's a example. 145 patients with critical limb ischemia, about 45% got stents, and they had a decent 93% limb salvage rate at 6 months. This is their niche here, though. This is a study they published in 2015 looking specifically at in-stent restenosis treatment. And again, these are bare nitinol stents that they're working on. They had 250 patients, and they actually had to stop the study early because there was such a significant benefit for the excimer laser versus PTA alone. And again, they looked at excimer laser followed by PTA versus PTA alone, and they had a higher procedural success rate, 93% versus about 83% for the PTA alone, and significantly fewer complications, 6% versus over 20% for the PTA alone, and significantly better 6-month patency of 73% versus 52% for the PTA alone. There's Las Vegas in the distance. It's about 25 miles from the top of that mountain. Just trying to summarize, and you can criticize these numbers a little bit, but these are kind of my best estimate. If you look through the literature, what would you expect with alternative therapies? As you know, balloon angioplasty doesn't have especially good 1-year patency rate in femoral interventions. Bare metal stents improve that, but there are some significant issues with stent fracture longer term. Drug-eluting stents, a little marginally better. Covered stents are pretty good for femoral interventions. The criticism of stents and covered stents in particular are that it can limit your subsequent options for either surgical bypass or other interventions. Drug-eluting balloons, as you know, look fairly promising in the SFA. Comparing those to the primary patency rates, at least the best I can glean from the literature for the mechanical thrombectomy devices, the Silverhawk, the Jetstream, the Diamondback, are in the mid to upper 70%, so probably a little bit lower than a drug-eluting or a drug-eluting balloon or a covered stent in the SFA. And the excimer laser, I think most of the published literature doesn't support that using primarily for de novo lesions in the SFA, but again, they have their niche of in-stent restenosis. So some of the take-home points, I think the data is still on the weak side, but it is improving since that Cochrane Review was published. I think if you look at papers out there, I think the directional atherectomy probably has the most supportive literature. Not that the other devices don't have supportive literature, but they just don't have as much out there. The atherectomy, I think, is generally safe, based on the current literature to use. The 3 non-atherectomy devices have 1-year SFA patency rates at least of, in the 75% range. Like I said, probably a little bit lower than I would say a covered stent or a drug-eluting balloon. And the excimer laser is inferior to the mechanical devices for de novo lesions, but has a good niche for in-stent restenosis. And that concludes my talk. And I got 27 seconds left. So.